we are going to examine three critical pathologies of the male genitourinary tract: varicocele, representing venous incompetence; Fournier's gangrene, a polymicrobial necrotizing infection; and the precise oncological algorithms governing testicular tumors. This 3D model of the male retroperitoneum traces the embryological descent of the testes from the upper abdomen down into the scrotal sac. This migration path establishes a central thesis: the testis and the scrotum possess separate, distinct vascular and lymphatic networks. These anatomical axioms are absolute determinants of clinical presentation. They dictate surgical contraindications, define staging pathways, and structure treatment algorithms. To memorize the rules of urologic surgery without understanding these specific anatomical pathways is to invite catastrophic clinical error. A varicocele is defined by the presence of a dilated, tortuous pampiniform plexus of veins, resulting directly from impaired venous return. Normally, the pampiniform plexus functions as a countercurrent heat exchange, keeping scrotal temperature 2 degrees lower than the core. When these veins dilate, the cooling mechanism breaks down. This chronic temperature increase impairs normal spermatogenesis, reducing sperm count, motility, and morphology. Due to this persistent thermal disruption, varicoceles are the most common reversible cause of male infertility. Unilateral varicoceles are overwhelmingly left-sided for 3 reasons. First, the left testicular vein enters the renal vein at a 90-degree angle, creating resistance. Second, the longer left renal vein creates a higher hydrostatic pressure column. Finally, a loaded sigmoid colon can physically compress the vein. Primary varicoceles follow these mechanical rules over time. However, a sudden onset left-sided varicocele in an older man requires immediate abdominal imaging. It indicates a secondary cause, specifically a renal cell carcinoma invading the left renal vein and physically blocking the ostium. While often asymptomatic, a varicocele can present as a dull, dragging pain that worsens with exertion and relieves when the patient lies down. On physical exam, particularly when standing or performing a Valsalva maneuver, the veins exhibit a palpable bag of worms consistency. It is easily distinguished from an inguinoscrotal hernia because the normal spermatic cord remains palpable directly above the purely scrotal swelling. The gold standard for investigation is a scrotal Doppler ultrasound, which confirms active venous reflux. Diagnosis is classified into 3 grades. Grade 1 is subclinical, detected only on ultrasound. Grade 2 is palpable during a Valsalva maneuver. Grade 3 is visible through the skin and palpable at rest. According to updated guidelines, management is reserved for symptomatic patients or those requiring specific medical fitness exams. The first-line intervention is now percutaneous embolization, an image-guided procedure offering fast recovery. If surgical intervention is necessary, the gold standard is a microsurgical varicocelectomy. Using a subinguinal approach under magnification allows the surgeon to ligate the offending veins while strictly sparing the testicular artery and lymphatics. Patients require clear counseling regarding outcomes. Due to the complex collateral drainage of the testes, there is a 20% recurrence rate. Furthermore, sperm parameters and pregnancy rates improve in only 30 to 40% of cases post-intervention. Fournier's gangrene is a rapidly progressive fulminant necrotizing fasciitis of the perineal and genital regions. If the destructive process extends superiorly into the anterior abdominal wall, the pathology is retermed Melanese gangrene. The etiology is a synergistic polymicrobial infection. It relies on the combined destructive action of aerobic and anaerobic bacteria, like E. coli and Clostridium. The condition is heavily associated with immunocompromised states, with diabetes mellitus acting as the most common predisposing factor. The bacteria are often introduced by seemingly trivial local trauma, such as shaving, scratches, or minor perianal abscesses. Clinical presentation begins with localized erythema, profound septic shock, and intense pain out of proportion to early physical findings. A highly specific diagnostic indicator is the presence of an overwhelmingly foul-smelling dishwater discharge. Crepitus, caused by gas production from anaerobes, along with purplish skin discoloration and bullae formation, are late signs of overwhelming systemic sepsis. Yet, in severe cases, a distinct anatomical anomaly exists. Regardless of how extensively the overlying skin is destroyed, the testis is remarkably spared. This cross-section explains why. Arterial supply is strictly compartmentalized. The testes draw blood directly from the aorta via cremasteric vessels. Meanwhile, the scrotal skin, which undergoes ischemic necrosis, relies entirely on a separate network of pudendal and femoral arteries. Management demands immediate resuscitation with rapid fluid boluses and broad-spectrum intravenous antibiotics, typically combining a carbapenem with clindamycin. However, medical management cannot succeed without immediate, ruthless surgical debridement. The surgeon must excise all necrotic tissue until healthy, bleeding tissue is reached, often leaving the testes entirely exposed. Hyperbaric oxygen therapy is utilized as an adjunct to further inhibit anaerobic bacterial growth and promote healing. This logic tree maps testicular tumors into two categories. Rare sex cord stromal tumors include Leydig cell tumors causing virilization and Sertoli cell tumors causing feminization. The massive germ cell branch seminomas, the most common, slow-growing type, and aggressive non-seminomatous germ cell tumors, including choriocarcinoma, embryonal carcinoma, and teratoma. Demographically, the yolk sac tumor is most common in prepubertal boys and secretes alpha-fetoprotein. Conversely, testicular lymphoma is most common in men over 50 and presents bilaterally in 10 to 15% of cases. The standard presentation is a painless, firm, solid testicular mass. Clinicians will note complete absence of normal visceral testicular sensation when gently squeezing the affected area. If a male patient presents with an unexplained abdominal lump, clinicians must immediately examine the genitalia. The lump often represents bulky para-aortic lymph nodes, a direct sign of lymphatic spread. Hematogenous spread primarily targets the lungs, creating classic cannonball metastases on chest imaging. The most aggressive variant, pure choriocarcinoma, earns the title of hurricane tumor. It rapidly outstrips its blood supply, causing central necrosis while metastasizing aggressively. The diagnostic workup begins with a scrotal ultrasound. This is the essential initial test to confirm the presence of a solid intratesticular mass, ruling out extratesticular fluid collections like a hydrocele. Accurate staging relies heavily on 3 serum tumor markers: alpha-fetoprotein, beta-HCG, and lactate dehydrogenase, a marker of overall tissue turnover. There is a critical biochemical rule here. A pure seminoma never raises alpha-fetoprotein. If initial biopsy suggests pure seminoma, but AFP is elevated, the tumor must be treated as a non-seminoma. This animated warning illustrates a strict oncologic rule: never perform a transscrotal biopsy or fine needle aspiration of a suspected testicular mass. The anatomical pathways dictate this rule. Scrotal skin drains into the inguinal nodes, while the testis drains strictly into the retroperitoneum. Piercing the scrotum drags malignant cells into a new lymphatic pathway, disastrously upstaging a localized, curable T1 tumor to T4. The correct standard procedure is Shavasu's maneuver followed by a high inguinal orchidectomy. A soft vascular clamp is immediately applied across the spermatic cord to prevent tumor embolization during manipulation. The testis is then split for immediate frozen section analysis. If positive, excision is completed. If benign, it is reposited. Staging is entirely pathological, determined post-orchidectomy. T1 is limited to the testis. T2 involves vascular or lymphatic invasion. T3 physically invades the spermatic cord. End staging reflects the embryological descent. Lymphatic drainage from the right testis targets the enter-aortocaval nodes, while drainage from the left testis maps to the left para-aortic nodes. In M staging, M1A denotes metastases to the lungs or non-regional nodes, and M1B indicates spread to distant solid organs. Crucially, there is no stage 4 in the staging system for testicular cancer. The system includes a unique S staging category. Quantitative serum markers must be drawn exactly 7 to 10 days post-operation. This waiting period accounts for biological half-lives. A persistent elevation confirms residual metastatic disease. When managing, clinicians look for specific markers. Pure seminomas displaying prominent lymphocytic infiltration indicate an active immune response, carrying a highly favorable prognosis. This flowchart tracks updated treatment algorithms. For stage 1 seminoma, 15% harbor microscopic metastases, making simple observation risky. The new standard is active adjuvant therapy. 1 cycle of carboplatin plus dogleg radiotherapy. For seminoma stages 2 and 3, the standard is BEP chemotherapy. Persistent masses require retroperitoneal lymph node dissection. Non-seminomatous tumors require maximum intensity. Stage 1 uses primary BEP chemotherapy. Stages 2 and 3 demand intensive BEP, systematic retroperitoneal lymph node dissection, plus metastasectomy for distant disease. Excellence in the management of scrotal and testicular diseases is an exercise in rigorous anatomical and biochemical logic. The laws of venous physics directly dictate the infertility patterns of varicoceles. Strict arterial compartmentalization saves the testis during the ruthless tissue destruction of Fournier's gangrene, and divergent lymphatic pathways formulate the absolute rule forbidding transscrotal oncological biopsies. By combining strict adherence to these embryological axioms with targeted therapies and precision surgical interventions, the management of testicular cancer stands as a major achievement of modern oncology, offering near-total curability even in advanced metastatic stages.